Good afternoon. My name is Bernadette Franks-Ongoy. I'm the Executive Director of Disability Rights Montana. We're a civil rights organization, and we advocate for people to live in the community and to have full integrated life. Today we're here with Alan Bergman, and Montana is in the process of preparing to close the Montana Developmental Center. It is our last institution for people with developmental disabilities. And Alan is an expert, and Alan is joining us to help give us some guidance on how we go about making this transformation here in Montana. Alan has been a provider, has provided services in the community. He's been a long-term provider. He's also had 18 years of helping develop policy, federal policy. Is that right, Alan?
Correct.
And you're also a dad of a person with a disability, so you understand it from a personal perspective as well. So we're going to talk with Alan today, and he's going to help us understand what other states have done in this process of deinstitutionalization and help us to navigate through this system. So with that, we're going to get started. Alan, thank you very much for being here, and I appreciate the sponsors that help bring you here. And those sponsors were Disability Rights Montana, Parents Let's Unite for Children, the Rule Institute, and the Montana Council on Developmental Disabilities, and finally the National Conference of State Legislatures also helped to bring you here to so that we could learn from you. So let's get started. Alan, tell us a little bit more about you before we start, if you think there's something I missed.
No, I think you covered it well, Bernie. Probably the best thing I can say is I've worn many different hats in my professional career around the country, and I have done training, technical assistance, and consulting in 46 of the 50 states. So I've seen where states are, what they're doing, what they did right, what they did wrong, and I've also lived through the myriad of changes we have experienced in this field since I first entered it in 1967.
Wow, that's fabulous. So as you know, our Montana State Legislature and our governor has made the policy decision to close our Montana Developmental Center. There's presently 52 people at the center,
right,
and they are thought of as being the most difficult to serve in terms of being able to integrate people into the community. So let's just start with, we've made the decision. In your experience, what are the things that we need to do to bring this into a reality?
Well, planning is the first thing to be done, but I had the opportunity yesterday to spend a few hours at the Montana Developmental Center. I didn't meet a lot of the current residents, but I met several, and I'm pretty confident, and then I've also talked with a number of the providers in this state, that there's no one currently at Montana Developmental Center who doesn't have what I would call a functional twin already living in, being supported, and being a member of the community. So part of this in every state that we've seen is there is this aura that gets created about the last 50, the last 100, whatever it might be, that those people are so unique they can't live any place but that particular state institution. And it's important, and I think the state knows this a little bit. We have 15 states now, the most recent being Oklahoma last August, where no one with developmental disabilities lives in a publicly operated state institution. That's a pretty significant piece. And then there are about 10 states, including Montana, that are down from 110 to about 35, and they're all moving because this is 2013 data, and at that point Montana had about 70. You're down to 52. I understand there are a number of people who already have plans as of yesterday to be moving over the next several months with providers, etc. So I think even in your state, the reality is there's nothing unique about the characteristics of people at MDC that people haven't seen before in the community, aren't serving in the community, and certainly true in every other state of this country.
There's been real concern, though, and there is evidently, well, there's a myth, I believe, that the folks that are in the institution are unique, and somehow they have a set of needs that just can't happen, can't be served appropriately in the community. Talk to me a little bit about your experience. Give us some examples, or what's that like?
Yeah. I think one of the things we have learned after decades of research in 9 states, where there have been 10-year trackings of people who have left institutions that have been closed, is everybody does better on every measure we have of what's called adaptive behavior, more independence, more friends, more relationships, and even folks who have what we call behavioral issues, those decrease. So I think the question is no longer, is there a unique population? The question is, how do we make the transition work based on what we have learned from everybody else in the country who's gone before. But we have longitudinal studies now, Pennsylvania, Connecticut, Oklahoma, New Hampshire, North Carolina, Kansas, Illinois, and California, and the results are, for all intents and purposes, parallel. That is, the people, in fact, with the most significant disabilities, that is, people who get labeled severe, profound, people who are older, and people with behavior challenges make the most significant gains by living in the community in a much more humane environment. No offense to MDC or any of the state institutions. I used to work in one 40 some odd years ago, but it's a very different mental set and set of expectations. And if the expectation is you're going to be a valued, contributing member of society and of community, you're going to teach differently, number one, but your expectation of how you approach the person is probably going to be with a different level of dignity and respect than if you're in the caretaker, protect them kind of set. And that's a training issue, that's an expectation issue, and what we're finding is people really blossom when they come out to the community, including the biggest gains, as I said, for people with the most significant disabilities and multiple disabilities. And I think that even surprised some of the researchers.
Right. You know, how we treat people with disabilities and how we serve them is an evolving process.
Absolutely.
I think from my experience, there was a time period when MDC and the present configuration of that facility was considered best practice and cutting edge. Talk to me a little bit about why that's no longer the best practice and where we're going.
Well, a number of issues have come to bear here. One is we've improved greatly the tools that clinicians and professionals have available, from positive behavior support. That's basically a strategy of how do we assist people to redirect their behavior without using punishment, without using restraints, without using chemicals. We have teaching strategies called task analysis and systematic instruction. We have all the power of tools of assistive technology, fancy word for an iPad or a smartphone or a reminder, which do wonders to enhance people's capacity and their strengths who have more significant disabilities, and also give them much more control over their life. And so when we create an environment that says, we expect you to grow, as opposed to we're here to protect you or protect some other group, that's a very different set of expectations. And it's not because of the staff being good or bad, that's the culture we have created. So the culture in the field has changed, and at the time that MDC went to the 11-person cottage, you are absolutely right. That was considered best practice then. Best practice changes every time we raise the bar on our expectations, and we can talk even now about what's going on in your community system. The typical approach in the community was a 6, 7, or 8-person group home.
Right.
We have now determined through research on quality of life that the best way for people to live in the community is in settings of 3 with a maximum of 4, but more importantly, where you get to choose who you live with, as opposed to in the old days, and again, I've been a provider, I run a 4-person group home, somebody moves out or gets thrown out or dies, I go to the state and say, okay, I need somebody, I got to backfill my vacant bed,
exactly.
And the person becomes a commodity without any malintent of anybody, and they may not like the people who live there, they may not know them, but you need it, we're taking you in. As opposed to, most of us like to choose who we live with, and again, let's be honest, in the world of domestic relations, where we spend time choosing our partners or spouses, the failure rate is over 50%. So why would we think by just throwing somebody into a vacancy that we're going to have a nice, happy marriage? And we don't.
Right. So culturally, we've definitely evolved. But also, there's been some really significant legal challenges, and the Supreme Court has talked about the rights of people with disabilities. And so tell us a little bit about the whole civil rights aspect of how we treat our brothers and sisters with disabilities.
Thank you. And again, what we're saying here is there are multiple quivers and arrows in the bow that have been going forward on parallel tracks, and they're all converging. So the civil rights agenda really started to emerge in the 70s and the 80s with the closure of the first institution, was a place called Pennhurst in Pennsylvania. That was a federal court decision, and Judge Broderick at the time said this place is unfit for human habitation. That's a direct quote from a federal judge, and he ordered it closed. However, that wasn't good enough. We had some other lawsuits we got there, but in 1990 and 1999, we had dramatic change. The Americans with Disabilities Act was passed in 1990, bipartisan, almost unanimous in both houses, and signed by then President George Herbert Walker Bush. And I was pleased to be at the signing ceremony on the White House lawn, a momentous day. That law, most people understand to be about access and employment discrimination. So wider doorways, electronic doorways, hallways, bathrooms with grab bars. That's cool, that's stuff. Title II of the ADA is about publicly funded services, and that's the guts of the civil rights piece for people with disabilities. And it says publicly funded services must, it's a mandate, be provided in the most integrated setting appropriate to the needs of the individual. And that got tested in the U.S. Supreme Court in 1999 by two women, Lois Curtis and Elaine Wilson, who were residents of a state institution in Georgia with complex disability, intellectual disability and a mental health disability co-occurring. But they wanted out. Most people said they ought to be out. And the state of Georgia said, sorry, we don't have any room, you'll have to wait. So a good civil rights attorney got a hold of the case, Elaine Jamison, took it to the federal court. They lost, they being the state of Georgia. They then sued and took it up to the federal Supreme Court, and on a 6-3 decision, the United States Supreme Court affirmed the civil rights issues in the Americans with Disabilities Act, and that segregation and discrimination are a violation of somebody's civil rights, and that there are teeth to that section of the law. That means institutions, by definition, which are segregated from the rest of us, are a violation of people's civil rights. And so going forward, the Department of Justice has become pretty assertive in a number of states, both in the developmental disabilities field, the mental health field, on residential, and now on sheltered workshops and day program, saying segregation is segregation is segregation, and it's illegal, and you're violating people's rights. We're dealing with human beings who have a right to life, liberty, and the pursuit of happiness in the community, no different from you and me.
Right. So there's So we talked about the culture, about how we're evolving. We've talked about how the law evolves.
Right.
One of the things is about helping people feel confident that this can work. And I think the group that is one that we have to work with and we have to shepherd into it is family members.
Sure.
They've been sold a bill of goods that their adult children are better served in this segregated setting. And so families need to be able to come on board. Share with us your experience about how do we do that with families? How do we get them to come along with us in helping to allow their child to live a fulfilled life in the community?
Yeah, no, it's a great question, and it's happened in every state. Is families bought what the professionals told them. They were the experts.
Right.
But again, we mentioned earlier, what's considered best practice 30 years ago, 40 years ago, 20 years ago, 10 years ago is a moving target. The models keep changing. The research tells us different things. And so the issue now is how to help a family get comfortable that they didn't make a bad decision, they didn't make a wrong decision, they listened to the best experts of the time, but That's now the Model T, and we've got the 2016 model, and we really need to get you to look at it. And I think that's the critical piece, is we can't just talk about it. We've got to be able to show it to people. They've got to be able to go look at it. They've got to be able to sense that, yes, my son or daughter or brother or sister can make it in this place because I'm looking at the other people here. And yeah, they're at least at their level or higher level, or however they do that. And then there's got to be an assurance from the state, and this gets really important, that the quality in the community will be stable and assured, and I'll come back to that when we talk about the community. But parents have to be dealt with, and family members, one family at a time. And I've lived through this with my stepdaughter, who was institutionalized at 5 in a different state. And that's because that's what all the folks told my wife and her former husband to do. Keeping her at home would destroy their family and all that kind of good stuff. Well, we sprung Mindy from the institution when she was 16, and for the first time in her life, she went to public school when she was 17. And at 21, she graduated with a certificate of completion, not a diploma. And this is a young lady with very significant and multiple disabilities, nonverbal. And I love Mindy dearly, and she's got more going than people give her credit for, but she fits that category. And Jan initially was like, what are you talking about? She's got to be here. She's got to be safe and whatever.
Right.
Fast forward, Mindy today is working 10 hours a week, making minimum wage when people never thought she could even make it in a sheltered workshop. We've raised the expectation, but Jan got to see it in a couple of other places and then say, oh my God, Mindy's not as disabled as that person. Let's give it a try. And we made sure the try was a good try. So I think the more we can show people where they can smell it, taste it, feel it, ask their questions, and the state can make some assurances it won't go away in 30 days or 60 days, because there's the perception the MDCs of the world will be there forever and guaranteed permanency. Well, that myth is now going away in 15 states.
So we help families to see it, to experience it, and we hold their hands along the way. And we have a system in place that really supports the family in this transition. One of the things that we've heard is that families are also very afraid of the abuse in the community, and the environments are not going to be as safe, and there isn't enough safeguards. And I think you started to allude to what's the state's responsibility or the oversight. So talk about that a little bit.
Well, there's multiple components. First, I'd like to deal with the myth of what you just said,
right,
in terms of the abuse. And it's painful, but we have good research data. Dr. Laurel Baldarian at UCLA has done this across the country for over 20 years. The biggest perpetrators of abuse of individuals with developmental disabilities, I'm painfully saying this, are family members and paid staff. It isn't the person walking down the street. Does that ever happen? Sure it does, and it happens to people without disabilities.
Right.
But the safety issue is another one of these myths we've created, that if we have a place and it is secure and it's campused and whatever, that life is going to be nirvana. It is absolutely not true. But the other part of this is, what is the capacity, the competency, and the skill set of the staff working in the community provider agency? And that's where the state does have a role in making clear that they're raising the expectation. They're going to have to raise their rates. They're going to have to raise salaries. They're going to have to talk about training. We have measurement indices now, 2 or 3 across the country that are acceptable. They're called personal outcome measures. They're called national core indicators. We can track in a provider objectively how are people doing. And again, this is a culture change. We're no longer taking care of people. We're not just maintaining them. We are assisting people to gain skills, to show us their strengths, to show us their gifts, and make a valued contribution called social capital to the community in which they live, as a neighbor, as a friend, as an employee, and as a citizen.
So we've talked about helping the family. We've talked about the myth about abuse. The other thing that we hear from family members and providers and other folks is, oh my goodness, if we don't have an MDC, if we don't have that facility, and my son or my daughter or the person I'm serving goes into crisis, what's the response to that crisis? What's the resource I have? What have other states done to prepare the communities to deal with those crises?
Yeah, and that's one of the essential components of what I call building the community infrastructure, to be able to have the full capacity to meet the needs of current individuals. And developmental disabilities isn't going away. There's a next generation coming, plus people are living longer. That's another thing the state needs to be thinking about. People are going to live until their 80s or 90s. When I first started, people were dying at 40. They're not dying anymore. So the system capacity issues are one. But the real issue here is, what is the crisis kind of stuff we're talking about? It's usually a behavioral episode. Somebody has a bad hair day, they start screaming, they break stuff, they hit somebody, they hit themselves. Those are kind of the repertoires. One, we have to provide better training at the floor level for providers to understand at least how to recognize it and what to do, and we call that positive behavioral intervention support. We don't need to restrain people, we don't need to tie them up, we don't need to slap them around, and we don't need to load them with medication. Step two, the state should put in place what we call mobile crisis teams, not buildings, not brick and mortar, maybe 2 or 3 in this state, maybe 4. You've got to use your telehealth network in this state, because you're never going to have enough folks given the square miles, and most states don't. And what we want to be sure is, if somebody really is having a behavioral crisis, that within, I would say, no more than 60 to 90 minutes, somebody from the mobile crisis team who is a trained expert shows up at that site, whether that's the residence, the place of work, in the community, wherever it is, and knows the right strategies to get the person to be stable for the moment, and then we're going to take them someplace, but we don't have to take them to a special place. One, the costs are cost prohibitive. Secondly, we have better ways that are more efficient. The one that I like to recommend, used in North Carolina and a couple of other states soon, is what we call renting a room in somebody's home. It's called a safe house, if you will. Mm-hmm. And we harden the walls, and we put in unbreakable glass or shatterproof glass, and we say to you, Bernie, we want you on retainer. We're going to pay you so many dollars a month, but you got to be there when we need you, because we're going to call you on an hour's notice and saying we're coming over with a trained staff and Susie. And we're probably going to be there a week to 10 days, and this is where we're going to stabilize Susie. It's a neutral environment, and we'll have a staff person there. We'll have already written a preliminary plan. We'll start doing some assessment. And one of the findings that is very painful through all of this, when we do good assessment, is very often the cause of the behavioral outburst is the person isn't in the right environment. It's not only them. They're responding to the environment in a way that they hope gets our attention, because what we also know is these behavioral episodes, unless they're neurological, are communication. It's a way of a person trying to tell us something that they don't know how to communicate verbally.
So it's not uncommon then that when someone goes into that crisis and they go to this safe house, that through that stabilization period, they determine that the person really would be better in a different environment, one that is more conducive to what they need.
For what they need, and again, it's one person at a time.
Right.
But in the data so far, over 80% have been, we've got to change the placement or the setting because it's toxic. It's just not working. And that's not a condemnation of the folks. There are folks you and I get along with just fine. There are other folks we would prefer to not be in their face.
That's
and have,
right.
Okay? And that is all, again, the core to all of this, and you know this, Bernie, we're dealing with real live human beings who have feelings just like the rest of us. They're not blobs of protoplasm. And the sooner we can make the cultural understanding that disability is a natural part of the human experience and it doesn't deprive you of any of your rights. There may need to be accommodations, there may be specialized supports, there may be all these other things, but the fundamental is this is a real live human being who has a right to be in the community and get the assistance to be all they can be. And every time we do that, oh my God, how did that happen? She's doing something she wasn't supposed to be able to do.
That's right. The other area is, I think there's a fear, and maybe you've already addressed it with the mobile crisis units and having safe houses, is there is a fear that people that are going to be coming out of MDC are somehow going to be having the pathway to prison and jail. And I don't believe that to be true. There have been a couple of cases here in Montana that someone has come out of the facility and ends up being in a jail. Is there statistics or is there anything to support that people coming out of institutions end up at a higher rate in correctional facilities?
Okay, and I want to separate two categories, I'm sorry to say. We're talking about people with developmental disabilities.
Correct.
Because on the mental health side, the data aren't as nice, as you know. In the area of developmental disabilities, again, is there an anecdote about a bad situation where somebody has ended up in jail? Absolutely. Not very frequent if we have the other pieces in place, one, and two, if we do some training with law enforcement. Law enforcement has to understand that there are going to be some new members of the community and good providers, not that we want to label somebody's home, but we sort of give alerts that on 27 Main Street, there's going to be a couple of folks there with disabilities, and saying we want the EMTs to know. It's just being smart, because there could be a medical emergency. Forget the behavioral one, to be sure to know that there's somebody there who might have limited communication skills or all this other stuff, and how to approach it. Particularly, we see a lot now with people with autism who tend to elope or walk out. So if I'm a police officer, and when I know that, how do I approach that person so I don't get them to be assaultive, to be attacking me, and then I want to arrest them because they're resisting whatever it is? So that's another piece of the training, and that has nothing to do with closing MDC. We've got people like this in the streets of every community right now.
Right.
So if we do that part right, if providers are trained right and have the right capacity, the likelihood of this happening is slim to none. I'm never going to say never for any of this. Stuff happens. It happens to people without disabilities, and we're not going to put a bubble around people with disabilities, because then we're right back to segregation and deprivation.
Right. So we've talked about families, we've talked about some the quality of providers and being able to support providers, and it's sounding more and more that this really is going to be a whole bunch of stakeholders coming together to make this work. One of the things that we're also trying to determine is the cost. So we know that it costs a lot to serve somebody in an institution, and we're in the process of trying to figure out whether or not it's true that we're going to be able to serve people in the community for less. What's your experience shown in terms of what it costs? Is institutional care more expensive? Is community care more expensive? Talk to us a little bit about that.
Let's talk in the aggregate, because that's how we look at state budgets. There's always going to be an expensive or two outlier in any state.
Exactly.
In the aggregate, the cost of appropriate community services and supports is significantly less costly once we do that infrastructure. There's some front-end investment costs to get the stuff in place. Anywhere from 15 to 30% less, and sometimes more than that. So I haven't looked at all the numbers here, but I know what the MDC numbers are. I have met with the providers here, a bunch of them, yesterday morning, and I've looked at your rates, and I've looked at your waiver, which is the funding stream. Your rates are very low. Your overall waiver costs are lower than the national average. So, and in my opinion, the state has sort of been nickel and diming the providers, and as a result, they've got high turnover. And if I put on my parent hat now, and I go out there and I ask about the staff, well, we're turning over about every 6 to 9 months on our hands-on staff. Guess what I'm saying? I ain't interested, okay? Right. My son or my daughter is complex, and by the time you get to know them, you're gone, and we got to start all over with John, who's coming on next week. Not that money solves that problem totally, but it sure makes a difference if we raise the base rate, we raise the standard of what the requirement is to do that work, and we train the person. The state's going to pay more, but you're going to have better quality because you're going to have better stability in the workforce. So it all, again, comes together. It's not one piece to the solution here, but states are doing this, and still at the end of the day, it's much cheaper because of two things. Your cost is cheaper. Your benefit and return on investment is off the charts, because if we do this stuff right, and start building community relations and what we call natural supports, friendships. You and I don't have natural supports, we have friends.
Exactly.
Okay? And friends start doing things with people, and they don't get paid to do it. We reduce the intensity of the staff costs. We use the technology, and I'm not saying people aren't going to have cost centers associated with them, but those plans of care start to go down, and their personal outcomes and quality of life go up. There's no losers here. This is win-win.
Right. So you've used the word infrastructure a few times in this interview. What are the components of infrastructure? I think even this morning when we were chatting, somebody had asked you.
Sure.
So tell me what you mean when you say we have to build infrastructure, we have to build capacity. Define that for us.
Right. And I'm talking now on the community side.
Correct.
MDC is going to be closing at some point. Okay? I want every provider to have competent staff, no matter who they're serving. That's piece one. To have competent staff, you've got to be able to recruit and retain competent staff. There is a wage rate issue. Secondly, there has got to be training and technical assistance about changing a culture, changing expectations, and giving people skill sets. That's not in the rate. I talked earlier today with people in the executive branch of government. There's going to have to be a couple of years, probably 3 years, separate line item for what we call the capacity building. Having training, technical assistance, ongoing for staff at all levels of community providers to get the skill sets they need to meet the expectations we're going to have for personal outcomes and quality of life and meaningful life, rather than we're going to take care of you, Bernie, come on over here, there, let's go. No. We want to lengthen the cord on you, not tighten it. And so that's a culture change, that's a skill set change. So that's a piece of it. The state then has to look at deciding as a purchaser, what are you buying? How much are you going to pay for it? And what's the performance measures you're going to use? And I mentioned a couple earlier. We have personal outcome measures that are valid and reliable called from the Council on Quality and Leadership. We have something called National Core Indicators funded by the federal government with 2 nonprofit agencies. So we have ways to start measuring. Are you doing good work? Provider A, provider B. And if you're not in the contract, we're coming in. We have a right to see. You're going to have 90 days to do a plan of correction, and we'll come help you. That's, again, an infrastructure. We'll give you some technical assistance. But guess what? If you don't get it better by a certain time, we're pulling your license. That shouldn't have to happen. But there's got to be a quid pro quo that the state, at the ultimate end of the day, is the responsible party. They are outsourcing. They are contracting for the services that technically they are responsible to assure are in place. But we know we can't do this in an MDC. We can only do this in dispersed, integrated communities. And the final piece we've got now is the federal government who pays for this, called the Center for Medicare and Medicaid Services, issued in January of 2014 what's called a settings rule. What are the kinds of situations that they're going to be willing to fund after 2019, which isn't very far away? They are built on that Olmstead Supreme Court decision and the ADA, and if you're living in the home that I'm running as the provider, I've got to assure that your life is not regimented, that you have autonomy, that you have control, that you have choice, and you have access to the full community based on what you're interested in, no different from me. That is a massive shift in what's going on and is going to have impact on licensing.
So one of the other parts that I think has happened here in Montana as we're now moving towards the closure of MDC, you have the community of Boulder that has been very concerned about the impact the closure of this facility is going to have on that community. How much of that should be part of this equation as we're moving forward and making this planning?
Okay. Again, not unusual, has happened in many states because the institutions often were built in remote areas, and then they grew up, or the towns grew up around them. So they're an innocent bystander and the people who work there. And so it's a very fair question. I can't deal with the economy of Boulder. That's a state issue in terms of, is there a way to use the property for another state purpose or whatever. But the piece that we should deal with is the state employees who work there. They are no more in charge of this than the people who live there. because the world has changed. But I take it out of our field and take it to the Rust Belt where steel mills have closed. People have had to figure out, what do you do next? We cannot allow those issues to say that people with disabilities will be held hostage and their rights will be violated and they will be segregated in order to take care of that. But every state that has done this well has had a planning component around redeployment of state personnel, starting with, are there other state jobs that they're qualified for and openings, including moving them if and the states pay for it. That's part of relocation. Okay.
Right.
2, are any of these folks close to retirement and you give them early pension buyouts? 3, are people wanting out and wanting to do something else? An appropriate severance package, no different. That again happens these are all options. Number 4, for people who really like doing this work and are good at it, what are some creative ways they can join the community provider workforce? One is, particularly as we do more and more of the supported living, host home living, adult foster care, again, closed community models, is do they meet the requirements? In 2 states, Washington and Vermont, they said, we want you to do this. We will give you preferential treatment. You have to meet all the licensing requirements. And it might even be that a particular staff person has a great relationship with 1 or 2 people currently at MDC. Fine, let's set them up as a boutique provider. They have to meet all the licensing and whatever. And last one is, are there openings in the current providers? And I know there's some new providers coming here where they could be a good job match and a job fit. So they're part of the planning equation. They should be given options and choices as well. They're not going to get a menu of 100 because we don't have 100, but 4 or 5, so at least they're not stuck in saying, well, I'm just becoming unemployed in 3 weeks or 3 months.
Right. So we're coming to the end of our time here, but we really have talked about several things. One, and I think I just kind of want to wrap some things up here.
Sure.
So clearly what we know from the experience of the other states that have done this, that over the long haul, this is the most cost efficient. It is cost efficient to move people in the community. That there are ways of dealing with crisis, and that there are successful ways of coming together and making sure that there isn't the pipeline to jail. The other thing, and I think most importantly, is it is legally the right thing to do, to be able to have people be able to exercise their civil rights by living in a community setting. 15 states have done it. I think fear is what, as I am part of this process, I hear really gets in the way of moving us forward. And I think that the information that you have shared with us helps to say, okay, let's really use real information to get past the fear. Give us some closing comments about how we should go as a state, and where do we go from here in terms of making this a reality?
Yeah, I think we've covered a bunch of them, but in terms of actual steps, there needs to be a plan. And key piece of that plan, even if you weren't closing MDC, but it's critical to it, is redesigning the current community services and support system for people with developmental disabilities. Again, it was great when it was created. It's outmoded. We're closing segregated sheltered workshops. The Department of Justice is. The federal government contracting program, Ability One, just said they're eliminating some minimum wage in the next 3 years from all of their contractors. The die is cast. This issue has moved down the field. And so now, what do we learn from the other states? So certainly what you pay providers, what the accountability is, what the training, technical assistance is critical. The mobile crisis teams is part of the infrastructure. But I would say, to be very honest with you, the best thing that needs to happen in this state is there needs to be real messaging to the education system and the special education system. We are going to raise expectations about what students leaving public school have in functional skills and employment skills. Again, we know how to do this. There are mandates and all kinds of new laws, and we don't want just watered down reading and writing and arithmetic, so that when they enter the front door of the DDP system at 20 21 or 22 or whatever, we've already got somebody who hopefully is working, who has a set of skills to know how to get around the community, hopefully has some technology, whatever. You want to talk about cost benefit and cost effectiveness? That next generation should look very different. And then, as we redefine the community, I've said this to providers yesterday, they don't like it, I'm sorry, no more buying real estate. Because once you buy real estate, you're into the beds and slots, and personal choice goes away. And I think that's the last thing, is in these new Medicaid rules, there is a whole set of rules about planning called person-centered planning and informed choice. Those are powerful tools giving control to the person and or their family about how I want to lead my life, which goes back again to making sure they have an opportunity to know what that could look like. So we're changing the landscape from the bottom up and, in the sense, from the outside in.
I really appreciate your coming and sharing your experience. I think that Montana is really on the verge of moving in that direction. I think the will of the state is here, and I just really appreciate your sharing this, and hopefully we'll be able to touch on your expertise in the future if we come up to a couple bumps in the road along the way. Do you have any 30-second closing comments that you'd like to make to our audience?
Well, first, thank you for letting me be here. I think the parting comment is simple. People with developmental disabilities, as we say, are people first. They're real live human beings, and they come with the full gamut of characteristics and likes and dislikes and personalities as you and me and the people we know. If we can start there, that not only is this a legal issue, this is a moral and an ethical issue, that we should deny nobody the right to full citizenship with the appropriate supports to be our friends, neighbors, and family members.
Alan, thank you so much. And we want to thank our sponsors for helping bring Alan to Montana to share his experience. And we're looking forward to this transitional process and, in fact, integrating our brothers and sisters with disabilities into our community lives. Thank you very much.